Chapter 5, Enteral and Parental Nutrition Support. Learning objectives. List consequences of malnutrition. Discuss the difference between enteral and parental nutrition. Identify disadvantages and possible complications of enteral and parental nutrition. Describe the types of enteral nutrition and their indications. Describe the three types of enteral feeding delivery methods. Explain refeeding syndrome and how it can be avoided and which patients are at the highest risk. Apply the nutrition care process to develop enteral and parental nutrition prescriptions. Explain the steps involved in determining the enteral and parental nutrition prescriptions. Calculate estimated nutrient needs for parental and enteral nutrition prescriptions. Determine amounts of calories and the micronutrients provided by parental and enteral prescriptions. Determine criteria for monitoring and evaluating enteral and parental feedings. With increased focus on the issues of overweight, obesity, and chronic disease in healthcare, it is important not to lose sight of the fact that insufficient food intake and the resulting protein energy malnutrition are of significant concern. As many as 30 to 50% of hospitalized patients and up to 95% of nursing home patients exhibit some signs of malnutrition. Almost 70% of hospitalized patients will exhibit a decline in nutritional status during hospitalization, and up to one-third of these patients will become malnourished. The Healthcare Cost and Utilization Project analyzed U.S. hospitalizations that involved the diagnosis of malnutrition. Estimations for malnutrition in children admitted to acute care hospitals range from 6 to 14% in Germany, France, the United Kingdom, and the United States. The consequences of inadequate nutrition and subsequent malnutrition include increased risk of infection, delayed wound healing, and delayed return to home, work, or baseline activities of daily living following hospitalizations. All of these consequences contribute to increased healthcare costs and diminished quality of life. Healthcare institutions, and in particular interdisciplinary clinicians, work to prevent or treat malnutrition. Anytime that individuals cannot meet their nutritional needs through an oral diet, they should be evaluated for enteral nutrition, tube feeding, and/or parental nutrition administration. The use of nutrition support is now recognized as an integral component of the medical care for patients that can blunt the stress response, reduce infections, and other medical conditions. Nutrition support via enteral and parental nutrition is a life-sustaining alternative for patients who are unable to maintain their nutritional status using oral diets or supplements. A comprehensive nutrition assessment is the first step to determine not only the extent of inadequate nutrition, but also the underlying cause of poor oral intake. Nutrition support is a significantly an extremely important component of nutrition interventions within the nutrition care process, and the nutrition practitioner will use it and its principles repeatedly in all areas of practice. Enteral nutrition refers to delivery of nutrients distal to the oral cavity of the GI tract via tube, catheter, or stoma. A stoma is an opening. The terms enteral feeding and tube feeding are used interchangeably in the clinical setting. The 2016 Aspen Critical Care Guidelines recommend that nutrition support therapy is in the form of early enteral nutrition be initiated within 24 to 48 hours in the critically ill patient who is unable to maintain volitional intake and it is at nutritional risk. I'll say it again. The 2016 Aspen Critical Care Guidelines recommend that nutrition support therapy in the form of early enteral nutrition be initiated within 24 to 48 hours. Enteral nutrition is indicated for adult patients who have a functioning GI tract and who present with inadequate oral intake for 7 to 14 days, or whom inadequate oral intake is expected to continue over a 7 to 14-day period. The recommended criteria for use of enteral nutrition in pediatrics include the following: unable to obtain more than 80% of caloric needs by mouth or requiring an extended time period to eat, more than 4 hours per day, or malnutrition or poor growth demonstrated by a decrease of two or more weight or height channels, or persistent tricep skin folds less than the fifth percentile. Enteral nutrition may be recommended for adult patients with altered mental status, swallowing dysfunction, or disorders of the upper GI tract that can be bypassed by inserting a feeding tube below the dysfunction. Enteral feedings are contraindicated if patients have serious medical conditions that affect the GI tract, including diffuse peritonitis, inflammation, or infection of the peritoneal lining of the abdominal cavity, GI bleeding, obstruction or ileus that prevents intestinal contents from passing through the intestines, or intractable vomiting or diarrhea not responsive to medical treatment. Research supports the use of enteral nutrition because of the following advantages: cost effectiveness, reduced length of hospital stay, reduced need for surgical interventions, reduced incidence of infectious complications in critically ill patients, improved wound healing, maintenance of GI function. Even when a patient is unable to meet all nutritional requirements completely with enteral nutrition, the use of tropic or trickle enteral nutrition may be prescribed along with parenteral nutrition. Atrophic feeding is providing enteral nutrition at a very low rate with the goal to maximize atrophy and prevent bacterial translocation. Disadvantages of enteral feeding include the potential difficulty of administration, poor tolerance, and difficulty meeting the nutritional requirement of some patients. These disadvantages may be minimized by careful patient selection through nutrition-focused physical assessment. After a thorough and complete nutrition assessment and determination that enteral nutrition support is both feasible and therapeutic, several important decisions are made in order to design the enteral nutrition prescription. The first is how to establish access to the GI tract. The access route is often determined by the primary physician accordingly to the patient diagnosis and the anticipated amount of time the patient will require support, the patient's disease state, aspiration risk, GI anatomy, gastric and intestinal function, and estimated length of therapy are evaluated. The types of feeding access is described accordingly to the tube, where the tube enters the body and where the tip is located. The tube may extend from the nose or naso or mouth, oral, into the stomach, becoming a nasogastric or oral gastric feeding tube. Nasogastric nose to stomach feeding is the most common, the easiest to achieve, and the easiest to maintain. It is also the least expensive and acceptable in most clinical situations. Small bowel or nasointestinal feedings enter the GI tract through the nose and resides in the duodenum or the jejunum. Nasal intestinal access or post-polyp feeding is preferred in some circumstances. Post-caloric access is used to bypass the stomach in case of gastroparesis or gastric outlet obstruction, or when previous gastric surgery precludes feeding into the stomach. A disadvantage of nasogastric or nasointestinal feeding tube is discomfort for the patient. Through smaller tubes may be palatable materials are typically used to improve patient comfort. Tubes entering the body through the nose or mouth are used for short-term therapy, normally less than 6 weeks. Registered dietitian nutritionists may be responsible for insertion of the nasogastric or nasointestinal feeding tube for adults in some institutions. A more permanent feeding tube can be inserted through the skin and is usually referred to by the location of the tip of the tube, followed by the suffix ostomy from the word stoma, meaning opening. A feeding tube, a tube delivery feeding to the stomach is a gastronomy, while a tube delivering feeding through the abdominal wall to the jejunum is called a genostomy. A physician places permanent feeding tubes while the patient is sedated. If a surgeon performs the procedure, it may be called a surgical gastronomy. Feeding tubes can be placed through the skin with a surgical incision with the use of an endoscope. This is referred to as a percutaneous endoscopic gastronomy or a PEG. The next step in establishing the enteral nutrition prescription is to be considered the following choice of enteral formulas. Enteral feedings were composed of liquid mixtures, blenderized foods from regular diets, or combination of baby food thinned with milk or juice. A major consideration in enteral feeding is the selection of the most appropriate formula from among the dozens available on the market. These products are composed of protein, carbohydrate, and fat with vitamins, minerals, water, and electrolytes in proportion that mimic a balanced diet or a diet designed for a specific disease or medical condition. Considerations for formula choice include the substrate within the formula, nutrient density, osmolality, and viscosity. Most institutions have an established formulary that provides the most cost-effective choice for each of several categories of enteral formulas. The protein component of enteral formulas is typically derived from soy or casein. The amount of protein range from approximately 10 to 15% of kilocalories for standard formulas to up to 25% of kilocalories for protein for high protein formulas. The majority of formulas called standard provide intact protein that require enzymes to split the nutrient into peptides before absorption across the epithelium in the GI tract. Formulas containing proteins from peptides called hydrolyzed or chemically defined formulas are used for patients with enzyme deficiency, malabsorptions, or other conditions resulting in maldigestion. Formulas with specialized amino acid profiles for renal failure, stress, and inborn error of metabolism have been developed from crystallized amino acids. Some formulas are supplemented with additional amounts of specific amino acids, such as glutamine and arginine. The disadvantage of peptide and crystalline amino acid products include increased osmolarity and higher costs. The carbohydrate sources for enteral formulas are molecules such as monosaccharides, oligosaccharides, dextrins, hydrolyzed cornstarch, and maltodextrins. Formulas are typically lactose-free. The carbohydrate composition of some enteral products include fructooligosaccharides, which, like an oligosaccharide, are fermented into short-chain fatty acids. Short-chain fatty acids are used by the colonocytes or colonic cells as fuel and play a role in maintaining GI integrity. Originally, formulas were fiber-free, but today many products are available with added fiber. Fiber is defined as a non-digestible plant carbohydrates. Functional fibers are extracted and manufactured, non digestible carbohydrates that are known to have beneficial effects in humans. Fiber added to formulas is generally thought to improve stool consistency and reduce diarrhea. Note, the evidence for the benefit of fiber added formula is actually mixed. The American Society of Parenteral and Enteral Nutrition Aspen guidelines recommend that a commercially mixed fiber formula not be used routinely in adult critical care patients prophylactically to prevent bowel regularity or prevent diarrhea. Enteral products contain only small amounts of soluble fiber because of its hydrophilic, meaning attracts to water, which causes the formula to thicken or to form a gel when fiber is added. Insoluble fibers, such as soy polysaccharides, are often found in enteral feeding because they are less hydrophilic. The fat or lipid sources for enteral formulas include corn, soy, canola, and fish oil, and safflower. These provide both long and medium chain fatty acids and serve as a source of both kilocalories and essential fatty acids. Concerns about the immunosuppressive properties of long chain fatty acids have increased interest in fat blends containing omega 3 fatty acids, which play a role in support of optimal immune function and by reducing the inflammatory response. Other products contain structural lipids and omega 3 fatty acids from fish and plant sources. Structural lipids are triglycerides that have specific fatty acids added and or whole chemical whose chemical structure has been altered. Remember that a medium chain fatty acid can be absorbed directly from the small intestine and bypass the steps of incorporation. Enteral formulas meet the dietary reference intake for vitamins and minerals for adult males and females within a specific volume, usually 1,500 milliliters within 24 hours. Pediatric formulas contain appropriate levels of micronutrients for infants and children. Some specialized formulas contain supplemental amounts for stress and wound healing. It is often necessary to compare the amounts of vitamins and minerals required by individual patients with the amount provided in the formula and to adjust vitamin and mineral supplements as needed to meet the patient's need. Many patients, particularly those with impaired renal, cardiac, or pulmonary function, are unable to tolerate large volumes of fluid. Therefore, nutrient density is of concern in product selection. The nutrient density of an enteral formula is measured in kilocalories per milliliter and usually measured between 1.0 to 2.0 kilocalories per milliliter. Standard feedings contain 1 kilocalorie per milliliter, which is consistent with the WHO recommendations for fluid intake, whereas nutrient dense formulas are manufactured with less water, so they contain 1.5 to 2.0 kilocalories per milliliter of fluid. Enteral formulas are often the primary source of water for patients receiving them. Thus, it is important to ensure adequate fluid intake. Patients who receive these products require careful monitoring of their fluid status to ensure that they remain adequately hydrated. An additional characteristic to note when choosing a formula is its osmolality. Osmolality refers to the number of water attracting particles per kilogram of water. Generally, those formulas that are partially hydrolyzed are considered to be chemically defined, having a higher osmolality. The osmolality of body fluids is 300 milliosmoles per kilogram. Isoosmolar enteral feedings were developed to minimize dumping syndrome or diarrhea resulting from rapid movement of fluids into the GI tract to dilute hyperosmolar or concentrated fluids. According to the Food and Drug Administration, enteral formulas are medical foods rather than drugs, and hence they are subject to FDA regulations for the accuracy of labels, claims, and standards of manufacturing. There is no requirement that enteral formulas be tested for efficacy or benefit for a particular disease or condition prior to marketing to the professionals or the public. Cost is an important consideration when selecting enteral products. Enteral products have been relatively inexpensive when compared to other components of healthcare, but newer products and those for specialized indications are increasingly expensive. The cost of products varies a great deal according to volume of product purchase. Many institutions implement a formulary system that limit the total number of products, resulting in an overall reduced cost. Patients who purchase few cans of formula from a retail grocery store or pharmacy typically pay a much higher price than large institutions that purchase thousands of cases each year. Enteral feeding ordering during hospital admission is covered within insurance coverage for hospital stay. Initiation and advancement of enteral feeding is based on clinical judgment, established institutional protocols, and current evidence-based guidelines. In the pediatric patient, it is recommended to initiate feeding as soon as the patient is hemodynamically stable. Progression is determined by tolerance. The goal is to meet 25 to 50% of estimated nutritional needs on day one of administration. In hospitalized adults, feeding should reach goal rate within 24 to 48 hours of initiation. In critically ill patients, feeding should be initiated within the first 24 to 48 hours of admission and meet 80% of the prescription within 72 hours. One of the concerns for enteral feeding prescriptions is that often a patient does not receive the prescribed formula rate due to the interruptions of feedings or for testing or intolerance. Recent literature have evaluated the benefit of prescribing enteral feeding by total volume rather than by rate. After the access and formula have been determined, delivery of the enteral feeding should be considered. Bolus feeding consists of administration of 250 to 500 milliliters of formula several times daily. A syringe may be used to inject feedings through the tube. Intermittent feedings also administered several times daily over 20 to 30 minutes. A pump is typically used to control the flow rate. If a pump is not available, formula may flow slow by gravity into the feeding tube from a container suspended above the patient. Continuous feedings are administered over 8 to 24 hours daily using a tube to control the feeding rate. Continuous feedings are preferred in the acute care setting as GI tolerance is maximized with this delivery. Continuous feedings are easier and less time consuming for staff to administer than bolus and intermittent feedings. A disadvantage of continuous feedings is the expense of the pump and the disposal equipment that is required for home use. Another drawback is restricted mobility for patients if the pump and other equipment are difficult to move. Sophisticated feeding tubes, feeding administration sets, and pumps have been developed so that enteral feedings are more comfortable for the patient and easier for patients or caregivers to administer. Feeding tubes continue to improve so that they are soft and palatable, resist clogging, and have flexible weighted tips. Most are made of polyvinyl, silicone, or polyurethane. The outer lumen diameter is described using a measurement called French size. 1 French equals 0.33 millimeters. Most tubes are 10 to 14 French. Enteral formulas can be provided in cans or in prepackaged sealed containers. Enteral nutrition is most often delivered using small pumps, similar to those used to control IV fluids. Figure 5.8, enteral formula in a ready-to-hang container. This can be found on page 103. The formula in these sterile containers is ready to be delivered to the patient. Figure 5.9, enteral feeding pump. This can be found on page 103. Enteral nutrition delivery is typically regulated by a small programmable feeding pump. The enteral nutrition prescription will be based on the registered dietitian nutrition's nutrition assessment and recommendations. The steps in determining the nutrition prescription are the following: establish dosing weight, the patient's stable weight from which calculations should be made, and protein, energy, and fluid requirements. Identify an appropriate enteral formula that is consistent with the patient's nutritional needs, digestive and absorptive capability, and diagnosis. Calculate the total energy needs and divide by the caloric density of the formula. Divide the total volume by the total number of hours over which formula will be administered. This is the goal rate. Determine initial starting rate and recommendations for advancement. Figure 5.10 is a sample of an adult enteral order form. This can be found on page 105. Table 5.2 is a sample enteral feeding protocol for bolus feeding initiation. So protocol and goal rate: begin feeding with Jevity 1.2 unless otherwise determined. Allow 4 hours between each step. Goal rate, let's say 60 milliliters per every hour, 4 hours, time 5 feedings while awake. This is just an example. Enteral feeding is not a simple procedure. Patients who receive enteral feedings may experience a variety of complications, and some of those, such as aspiration or tube misplacement, are serious. Complications of enteral feedings may develop at any point during course of therapy. High-risk patients who have concurrent illnesses require an experienced registered dietitian nutritionist to successfully manage enteral feedings. In order to ensure that complications do not develop, it is important to determine whether the patient is medically stable and how long it has been since enteral nutrition was started. Patients for whom enteral nutrition is newly initiated should have more intense monitoring during the feeding rate progression. The frequency of monitoring can be diminished as the patient becomes stable. Patients may not receive the prescribed enteral nutrition when feedings are stopped for testing and other medical procedures and not restarted appropriately. Misunderstanding of intolerance to feeding may also result in feeding being stopped inappropriately. The tube feeding, the enteral tube should be placed by a well-trained physician, nurse, or registered dietitian nutritionist in order to minimize the risk of tube misplacement. Clogged, twisted, or kinked feeding tubes may result in reduced or delayed feedings as well as other medical complications. Clogged tubes may often result from administration of medication through the tube or from inadequate flushing. To prevent clogged tubes, the feeding tube is flushed with a syringe containing at least 25 milliliters or more of tap water several times daily. GI complications, diarrhea, constipation, bloating, and gas may result from the use of enteral feedings. Diarrhea is enterally fed patients may result as a complication of antibiotics or consequences of administration of other medications via the feeding tube. A recent study determined that constipation is actually a more common complication than diarrhea. Aspiration occurs when fluid is inspired into the lungs. Patients who are sedated, who have an endotracheal tube, or who have difficulty swallowing are also at risk for aspiration. Residual volumes of liquid in the stomach have also been used to determine whether a feeding was empty from the GI tract, but guidelines for this practice are not well established. It is also recommended that enteral feedings be stopped only if there is defined regurgitation or aspiration of gastric contents or the residual greater than 500 milliliters is measured. Aspen 2016 guidelines do not recommend the use of gastric residuals to monitor tolerance of enteral feedings. Dehydration: patients with insufficient fluid intake who are receiving enteral feedings may develop hyperosmolar non-ketotic dehydration over a short of 2 to 4 day period. The condition may be prevented by providing sufficient fluid with the feeding. Patients receiving less fluid should be monitored with a daily fluid assessment. Electrolyte imbalance. In stable patients receiving enteral nutrition, the DRI for sodium, potassium, calcium, magnesium, and phosphorus are often used as a guide for electrolyte intake. It is imperative for clinicians to understand that enteral and parenteral fluid requirements differ due to the needs for absorption with enteral delivery, but not IV delivery. Overfeeding or underfeeding. Enteral feeding is based on a dosing weight established by the registered dietitian nutritionist. Every attempt is made to feed the patient an appropriate amount of nutrients based on their weight. Both underfeeding and overfeeding can be detrimental to the patient. Underfeeding may delay nutritional replention and fluid wound healing. Overfeeding may lead to a condition called refeeding syndrome. Hyperglycemia can appear even in patients with no previous history of diabetes. Guidelines for the treatment of hyperglycemia during nutritional support vary between critically ill and non-critically ill patients. Typically, insulin is initiated when blood glucose is greater than 180 milliliters per deciliter. Refeeding syndrome is a term used to describe several common metabolic alterations that may occur in patients who are malnourished or in a state of starvation. The word parenteral means alongside or outside the GI tract and is now used to describe the administration of drugs or nutrients by vein intravenously. Parenteral nutrition developed in the 1960s to sustain the lives of individuals with severe GI impairment and includes IV nutrients delivered through a peripheral vein or central vein. Parenteral nutrition was previously referred to as essential venous nutrition or intravenous hypoalimentation, but parenteral nutrition is now used to encompass all IV delivery of nutrients. The term parenteral nutrition refers to the administration of large volume diluted solutions of nutrients into a small vein in the arm or back of the hand. PPN is described for short-term use and is most commonly used as a therapy to provide nutrients whole awaiting placement of a central venous catheter or CPN. The high osmolality of PPN may cause small veins to collapse, and peripheral access is difficult to maintain for more than a few days. The osmolality of the PPN solution should be confirmed to be less than 900 milliosmoles per liter prior to the administration through a peripheral vein. Parenteral nutrition is indicated in those clinical situations where the patient is unable to meet nutritional needs, whether by an oral diet or through the use of enteral nutrition. The clinical conditions that require parenteral nutrition include an inability to digest and absorb nutrients, such as in massive bowel resection or short bowel syndrome, intractable vomiting, GI tract obstruction. Nutrition diagnoses associated with candidates for parenteral nutrition are the same as those for enteral nutrition. All right. The primary difference between enteral and parenteral feeding is that the nutrients are provided via the veins through a vascular access device or VAD rather than the GI tract. In parenteral nutrition, feeding directly into the venous system and large diameter veins allows for the use of high osmolality solutions greater than 900 milliosmoles per liter to allow delivery of 100% of estimated nutrition requirements. The location of the catheter tip determines if a PPN or a CPN solution can be infused. Short-term VAD. The most common VAD is a central venous catheter or a central line inserted percutaneously through the skin at the bedside while the patient is under local anesthesia. Central catheters are inserted into large veins such as the subclavian or femoral veins. Central venous catheters are usually changed every few days to help decrease the risk of infection inherent with an opening from the skin into a large central vein. The excuse me. The peripherally inserted central catheter, PICC, is often used. Unlike the CVC, which requires a bedside surgical procedure by a physician for insertion, the PIC can be inserted by specially trained nurses. This increases availability of the procedure and decreases costs. PIC lines are inserted into the arm and threaded into the subclavian vein to the vena cava, where the tip resides adjacent to the right atrium. For long-term use or for home parenteral nutrition, a catheter is tunneled under the skin using a surgical procedure. Tunnel catheters most often enter the vein on the upper chest wall and exit the body near the xiphoid process or abdominal wall. Implantable ports are similar to tunnel catheters in that they may be placed in an operating room by a surgeon. They lie completely under the skin and are more acceptable for patients with body image concerns. Unlike enteral formulas, which are most often purchased in a form appropriate for patient administration, parenteral formulas are mixed or compound in the hospital pharmacy. The method the pharmacy used to compound parenteral nutrition preparations is critical to development of the parenteral nutrition prescription. Advantages of this approach include improvements in efficiency and cost effectiveness. 2-in-1 system. The formula includes dextrose and amino acids with lipids added separately. Advantages: greater flexibility in amounts of dextrose and amino acids. Disadvantages: requires 2 administration sets. Three-in-one formulas. The formula includes dextrose, amino acids, and lipids. Advantage: requires 1 administration set. So a disadvantage is that it's opaque, so you cannot observe precipitates. Electrolytes and final concentration of amino acids are limited. Protein is included in the form of individual amino acids in amounts consistent with the Food and Agriculture Organization and the World Health Organization recommendations. Modified products have been developed and marketed for renal failure, hepatic failure, and stress. Factors that increase protein requirements above the DRI include diagnoses such as trauma, burns, sepsis, wounds, and bone marrow transplant. The lower range of protein, 0.8 grams per kilogram, may be needed for patients with acute kidney injury or who's not receiving dialysis. It is important to remember, however, that without adequate energy from carbohydrates and lipids, the subsequent catabolism of lean body mass defeats the effect to control uremia in this matter. The primary function of parenteral carbohydrate is to serve as an energy source. Dextrose monohydrate is the most common in the US and provides 3.4 kilocalories per gram. 1 milligram per kilogram per minute is used as the reference for the minimum amount of carbohydrates needed to spare protein. Commercially available, you have 5%, 10%, 50%, and 70% concentration. Excessive carbohydrate may contribute to hyperglycemia and excessive carbon dioxide production. The intravenous lipid emulsion is most parenteral solutions available in the US since 1972. Other sources of lipids that contain fewer total omega-6 fatty acids and more omega-3 fatty acids have been developed, but were unavailable in the US until 2013. Product these products provide essential fatty acids and vitamin K in addition to energy. Available in formulations contains 10, 20, and 30% concentrations. Complications include hypolipidemia and impaired immune response. The medication propofol, which is often administered to the critically ill, is lipid-based and thus must be considered as a source of energy. Electrolytes. Requirements are based on body weight, existing electrolyte deficiencies, ongoing electrolyte losses, and changes in organ function. Vitamins and minerals. Most pharmacies use commercial multivitamin preparations. Trace element preparations purchased commercially. Include delivery of medications such as insulin, albumin, heparin, and others. Prior to recommending medications be added to the parenteral nutrition, the clinician should gain a thorough understanding of the practice at his and her institution through observation and consulting with a pharmacist. The parenteral nutrition prescription will be based on the registered dietitian nutritionist nutrition assessment and the physician and pharmacist recommendation, and is often communicated using a form. The basic steps include the following: estimation, establish dosing weight and energy requirement, calculate protein goal and start first parenteral solution with goal protein, distribute remaining kilocalories between carbohydrate and lipid, ensure first parenteral nutrition solution has less than 200 grams of dextrose, consider holding the lipid in motion for up to 7 days if in the ICU, consider the electrolyte needs for the patient. Add a vitamin and mineral preparation, consider trace element requirements, establish fluid requirements, calculate the final parenteral prescription. Figure 5.15 is a sample of an adult parenteral nutrition order form. It can be found on page 116. Aspen recommends standardized protocols for delivery of parenteral nutrition. It is recommended that a standardized order form be used to ensure basic nutritional needs for patients are met and that errors are minimized. Parenteral nutrition can be cycled or delivered continuously over a 24-hour period. The initial parenteral nutrition solution should not exceed 200 grams of dextrose to prevent parenteral nutrition, induce hypoglycemia, and increase risk of infectious complications. Intake and output initiated to account for fluid and electrolyte losses, includes testing for hypoglycemia, includes daily measurements of electrolytes, BUN, creatinine, magnesium, and phosphorus. Lipid tolerance assessed. If abnormal, they may be drawn weekly thereafter. Complications may be severe. GI complications primarily in patients whose GI tract is at complete rest. Transient liver enzymes, elevations with parenteral nutrition lasting several weeks, serious infections. Patients transitioning from one form of specialized nutrition support to another require careful consideration to prevent overfeeding and hypoglycemia. Confirmation of adequate bowel function is necessary prior to transitioning off of parenteral nutrition. Discontinuation of parenteral nutrition should be considered once 50% of estimated nutritional needs are delivered via the GI tract. Patients unable to meet 50 to 60% of estimated nutrient needs on enteral nutrition. Supplementing parenteral nutrition can be considered until enteral nutrition can be advanced or even tolerated. Initiation of home parenteral nutrition can occur in the home, but preference is given to starting the therapy in the hospital setting in patients with electrolyte abnormal abnormal electrolytes and severe medical conditions. monitoring protocols from home parental nutrition or similar for the hospitalized patients discussed before, but most include tactics for prevention of metabolic bone disease, intestinal failure associated liver disease, and catheter line associated bloodstream infection. Parental nutrition products shortage, multivitamin solutions. First, document parental nutrition products shortage recommendations. Prioritize products to vulnerable populations. Consider enteral delivery of nutrients when possible. Evaluate alternative supplies and protocols to prevent waste. Clinical ethics. The role of the registered dietitian nutritionist in the clinical setting, decision making for using specialized nutrition support during end of life should be based on evidence based medical medicine, incorporating benefit, risk, burden analysis with thorough discussion with the patient and family member.